Good morning, everyone. Thank you for joining. On behalf of World Health for the World, good morning to everyone again. Thanks for joining today's rheumatology grant rounds, which is titled Approach to a Child with Joint Pain. And our guest speaker is Dr. Beth Gottlieb. Dr. Gottlieb is an associate professor in pediatric rheumatology in Long Island Jewish Medical Center and North Shore University Hospital. Dr. Gottlieb completed her medical training at University of Tel Aviv in Israel and then continued her pediatric residency at Long Island Medical Center. She continued her training in this same institution in pediatric rheumatology and has dedicated her services to this same institution throughout her career. Dr. Gottlieb is also the current chief of pediatric rheumatology and has contributed in many active clinical trials. So, Dr. Gottlieb, thank you so much for your time. Please take it away.
Wonderful. Well, thank you so much for inviting me today. I'm really happy to talk to you about the approach to the child with joint pain. So I'm going to share my screen with you and begin. And we'll talk about the basics today about how we approach the child who has musculoskeletal pain. So we're going to talk about how we evaluate that child, and really most of what we're going to talk about are really common things that affect children. Musculoskeletal pain is extremely common in children, and so we see joint pains really in most of the kinds of pediatric practices that we have. And really most specialties might hear, if they're doing any kind of basic history, about joint pains in children because they are so very, very common. And really with a good history, we should be able to understand the basics of joint pains in children. And it is not very common to actually make a diagnosis of a rheumatologic disease in children who have these very common pains. We rarely need to do further diagnostic testing by the time we're done with a good history and physical exam. So we do have a role for labs and imaging, but again, not very commonly do we need to go ahead and order those. So I want to talk about how we recognize the signs of a common musculoskeletal pain in children. So most importantly, we talk about location. Where is that pain? Does that pain radiate somewhere? How long does that pain last? Some children will talk about terrible, severe pain, but when we ask how long it lasts, it may only last for minutes, or it might be that they feel like it lasts a long time. But when we ask them in a child's term, does it last for as long as a TV commercial? Does it last for as long as it might take for you to walk over and tell mommy or daddy, or for as long as it might take to kind of shake it out? That's all it lasts, which really amounts to minutes. It may feel like a long time in a child's sense, but it really isn't very long at all. We talk about associated symptoms, what else is happening with those joint pains. And then we look for what we call inflammatory versus non-inflammatory symptoms. And I'll explain those more later. So let's first talk about location. Is it a joint? Is it muscle? Is it bone? And we really want children to point, because they may talk about knee pain, but when they point, they may actually be pointing to a location below the knee. And that's very, very different for us than the actual knee itself. So having them actually tell us and show us is really quite important. And it helps a great deal, because for a child and even an adult, they may not know what to tell us about where that pain is. We also think about referred pain. So pathology in the hip could be referred to the groin or even the knee, and vice versa. Knee pain can be felt in the hip itself. So if you think that the child's telling you about their hip and you do a hip exam and it has full range of motion, be sure to pay attention to the knee, and again, vice versa. Is it in one location or many locations? If it's a single joint, we might think about a septic joint, about trauma, about juvenile arthritis. Multiple locations might have us think about hypermobility syndrome, which we'll talk about more in a minute, juvenile arthritis or connective tissue disease. Post-infectious things like reactive arthritis could be in multiple joints. And then clinical symptoms that go together. Juvenile idiopathic arthritis is the new term for juvenile rheumatoid arthritis. So we now call it JIA. And I believe you have another talk coming up from rheumatologists about that later. So I won't go into details about JIA in this talk, but that involves persistent swelling. And the key here is joint effusion must be present for a minimum of 6 weeks, and it needs to be documented. Families tell us all the time about joint swelling, but when we go to examine, we don't actually find joint effusion. And there's a big difference between subjective swelling and true joint effusion. There could be soft tissue swelling present, but again, that does not mean it's the same as a joint effusion. And only a joint effusion would be the same as arthritis. Again, there are other things that could go into the picture of arthritis, but that's going to be saved for a different day. JIA could have an insidious onset too. So sometimes people will say, we just noticed this swelling for a week, but when we examine, we might actually find muscle atrophy. That tells us that that has been present for much longer than a couple of weeks, because muscle atrophy clearly takes a long time to happen. And we might actually say, we know that's been there for more than 6 weeks already. Hypermobility symptoms have a specific set of clinical symptoms that go with it. And we often hear this very specific story. The pains are brief, they're self-limited, there's never swelling associated with it. And again, we hear that very typical kind of story associated with it. Again, I'm going to show you a specific slide about that too. Septic arthritis, really different clinical picture here. That's a toxic appearing child. They have fever, they really appear sick, they have terrible pain. They don't want you coming near them, that hurts so much. There's swelling, there's warmth, there's fever. Very, very different kind of clinical picture. So hearing the story gives us our first indication of what's happening. So I just mentioned a lot of associated symptoms. Swelling, erythema, warmth gives us a very different picture of true joint effusion, of true arthritis. Erythema, we rarely see in JIA. We see that in septic arthritis. So don't be surprised if you don't find erythema often. We do always feel for warmth over an inflamed joint. Fever, if we find that, that gives us a whole different set of a differential diagnosis, but fever could be reactive arthritis, septic arthritis, one particular form of JIA, which is systemic onset JIA, and we think about malignancy too in very specific kinds of cases. Other associated symptoms, we think about rash. We always ask about that. And we might see rash in a viral syndrome that's caused some arthritis. We could see rash in systemic JIA. Lyme disease has rash. So rash is always an important sign for us. We always want to know about that history. We talk about eye symptoms. Juvenile arthritis could have eye symptoms, although usually it's asymptomatic and only picked up by an ophthalmologist. But reactive arthritis, such as Reiter's syndrome. And that's that triad of conjunctivitis, arthritis, and urethritis. So we want to ask about eye symptoms too. And then stomach symptoms, stomach ache, diarrhea, frequent stool, because sometimes arthritis could be a first sign of inflammatory bowel disease. Also, reactive arthritis might start after a stomach bug, after a gastroenteritis. So these are all important things to ask about. History of recent illness, which maybe it was a week or two ago and they're all better, but now they have a reactive arthritis, and that could be very typical timing. Recent immunization. We don't see that as much anymore, but that used to be more common. Preceding trauma, was it an injury-related arthritis or injury that caused joint pain? And then a change in activity level. This can be tricky because our children who have juvenile arthritis are often able to continue their activity. So this might be a tricky one, but it's certainly something still we ask about. Timing of pain, important. So we ask about, is their pain worse in the morning, afternoon, or night? Is it better after they rest, or is it better with activity? Children with juvenile arthritis are worse in the morning. They're actually better when they move around and are more active. When it's non-inflammatory pain, and that is caused by overuse, activity makes them worse. Children have a very hard time with the concept of morning stiffness. So we might say that to an older teenager, but in younger children, we say, is it hard to bend or straighten when you first get out of bed or after a long car ride? And then exam. If we're fortunate, our exam starts as the child enters the room. Are they being carried? Are they limping? Can they take their clothes, their shoes and socks off all by themselves? Do they need help because they're having difficulty? Can they get up on the exam table by themselves? So these are important signs right from the beginning. Do they have systemic symptoms, rash, weakness, etc.? Look before you touch. Does it look swollen visibly? Sometimes we see it right away. And then feel the joints. Are they warm before you start to touch them? And feel with the same side of your hand and your same hand. And compare equal sides of the joint. So the inner side to the inner side on the right and the left side of that joint. And again, where does it hurt? Is it joint, bone, muscle, or entheses? Entheses are the insertion points of tendons, and they can be quite painful too. Now I'm going to show you a video that I've done of a joint exam, and it takes a long time to practice looking for joint effusions, but this will give you an idea of what we do during a rheumatologic musculoskeletal exam. But this is a good exam to do to look at range of motion and so forth. So just give me a moment while I pull this up. We begin the exam by asking the children to hold up their fingers and fold their fingers down like this. This shows us the movement of the PIP and the DIPs. You can see how their fingers would be flat. If they're unable to do that due to finger swelling, you might see some fingers go down flat, where some fingers are unable to go down all the way. After they do this, we ask them to fold their fingers all the way down. This also gives us the movement of the MCP joints. Then we ask them to put their hands together and push their arms upward, making a nice 90-degree angle between the wrists and their forearms. That shows us that they're able to have full extension of their wrist joints. We can then ask them to go backwards, folding their wrist down, showing us flexion of the wrist joint. Extension is a more important movement because this is very important in grip strength. So for functional ability, we're much more concerned about the ability to extend the wrist all the way. After we've done that, we ask the children to raise their arms straight up over their head with their elbows straight. Then out to the side and touch their shoulders. Now we've seen their elbow movement and their shoulder movement. We then ask them to put their hands behind their back. This pulls their shoulders down and helps us to look at their cervical spine better. We ask them to put their chin down to their chest for forward bending, and then look all the way up to the ceiling for backward bending. And then for rotation, we ask them to put their chin to their shoulder, looking side to side. And finally, we have them put their ear to their shoulder for lateral bending. And that completes the upper extremity and the cervical spine. So in order to feel the joints of the wrist, we put one hand underneath and our other hand on top. So we're going to put our two parts of our hand, our thumb and our second finger, around the wrist joint here. And our other hand is underneath holding the wrist. This leaves us our thumb at the top. And our thumb is going to feel at the wrist joint itself. So the thumb is feeling in this part here of the wrist joint where there's a small indentation in the joint space. If there is fluid, as we're pressing down with our thumb, these fingers will actually feel like they're getting pushed apart by that pressure and that fluid. So gently, we're pressing down with our thumb onto that spot of the wrist to see if it's pressing these two fingers apart. We also look to see if there's any visible swelling here over the top of the hand. If there's a very large joint diffusion, we may actually see a little bit of raised swelling here. We also feel for warmth. We should actually do that before we've started to touch. Once we start to touch a lot, we'll actually increase the warmth over the skin. Always feel with the same hand to the left and the right side and compare for warmth. The top of your fingers are a little bit more sensitive to feel temperature. Once you've done the wrists, then you would go ahead and look at the finger joints. And we're going to feel here at the MCP joints, the PIP joints, and the DIP, as well as the thumb. And I'm not going to do them all, but I just want to show you how you would go about feeling them. The joint space is actually here at the side. And we're going to feel, I like to feel with my two thumbs back and forth. And you can feel the crevice, the line, right over at the edge of the joint itself. And that's what we're going to do. We're going to feel pushing back and forth between the joints here, between the second and third finger, and here on the edge of that second finger, we're pushing back and forth to see if there's any fluid. And then you can move to the next MCP joint and do the same. It takes a lot of practice to feel if there's actually fluid there or just thickening if there's been some chronic inflammation. For a PIP joint, we're having two fingers on the top of the joint and two fingers on the side, and we're actually going to push back and forth to see if there's fluid going between our fingers. So two fingers on the sides of the joint, two fingers at the top and the bottom, and these fingers are now going to squeeze gently to see if these two fingers are getting pushed aside by any fluid. So a gentle push here with my top and bottom fingers, seeing if the side fingers are getting pushed aside. We're going to do that also with the DIP joints. In addition to feeling for fluid, we're checking to see if it's tender when we're pressing on those joints. We're also going to do movement again, and although we've asked our patient to do this for us, we're also going to press down and up on the MCP joint. It should go in both directions. It should flex and extend. So we're going to do that on the joints. We're going to, again, press down to flex fully, and the DIP, hold it steady and wiggle the DIP joints. And we're going to do that for both hands. For an elbow, we always want to try to fully extend when we're trying to check for fluid. So extend the elbow, and we're going to be feeling all the way here at the back of the joint. You can feel in the groove here at the olecranon fossa, and you want to try to feel for any fluid. Again, we've already felt for warmth. We're starting that right away. We're looking to see if there's any swelling, any bulging. It's very rare that you would actually look and see swelling at an elbow, right? But you do want to just feel there for any pocket of fluid. Often, if there is fluid in one of these joints, like an elbow or a knee, it feels like you're pressing into a full water balloon. Right? And we're going to do that on both sides. Then we're going to flex all the way and extend. And you can also turn and see if they're able to rotate here too. Okay. A shoulder joint is all the way in here. Many people are feeling all the way out here, and that, of course, is not the joint space. So you really want to feel all the way over in here, and you can feel the groove of the joint here, and it goes all the way up and along here, alongside of the humerus, the top of the humerus here, the proximal aspect. So you want to be feeling in this groove. It is very rare to find arthritis in a shoulder joint, but one of the common things that we do find related to pain is a biceps tendonitis, and you can press in here and see if there's any tenderness. If you feel tenderness, you can feel the tendon. You can actually roll the tendon here. It's quite tender if there is some inflammation of that tendon. Right? To finish your exam of a shoulder, you can hold the arm out and rotate. And remember, we've already asked the patient to be raising and extending their shoulders out to the side. And here we get 180 degrees of shoulder rotation. And that gives us a complete exam now that we have palpated the upper extremity. To examine the hips, we have our patient lying flat. And now what we're going to do is we're going to flex the knee, which also flexes our hip. And we're able to do two things at the same time. We're able to see that the knee can flex all the way. And then we cross our ankle over the other knee. We tell the kids that they're making the number 4, and we let the hip just extend all the way, and you can see this beautiful external rotation of the hip. And then we do the other side. And flexing our knee all the way. Most young children are able to flex all the way, and they're able to kick themselves in the behind so that their ankle touches all the way to meet their thigh. Not everybody can do that. As long as it's symmetric, it's normal. And again, here we have beautiful extension, external rotation of that hip. right? The other thing that we do while we're in this position is check the sacroiliac joint. We do something called a Faber, flexion, abduction, external rotation, and extension. And we stress our sacroiliac joint. Once we're in this position, we press with one hand on one side of the pelvis and press on the knee, and this stresses the sacroiliac joint. And if that causes some pain that's really radiating toward the buttock, that would tell us that we're causing some pressure and some discomfort at the sacroiliac joint. And we would do that on both sides. The other test that we do for the sacroiliac joint, if you just slide to the edge of the table for me, we do a maneuver called the Gainsland. And we take one leg and we flex our knee all the way, and we drop the other leg off the edge of the table and we press. Again, this stretches that sacroiliac joint. Yeah, that's perfect. Thank you. And we see if that causes any discomfort. And then if you just, well, so before that, what we can do also for sacroiliac joint is compress the pelvis to see if that hurts. And finally, if you just sit up, we would have our patient sitting, and then in this position, we press over the sacroiliac joints in the back. And so those are the maneuvers that we do for the sacroiliac joint. To examine the knee, you want to make sure the patient is lying flat with their knee flatly against the exam table as much as possible. We always want to remember that fluid will level out with gravity. So we want to try to push any fluid down from the prepatella bursa into the joint itself. Always, again, start to feel with the same hand for any warmth. Feel at the ankles. Strictly speaking, ankles should feel cooler than the knees. That goes despite what we might think that it should be cooler as you go more distally, but this actually isn't true. Knees should feel cooler than ankles. Practically speaking, I'm not sure I often find that, so just be careful and think about whether or not it's symmetric. Knees could also be warmer on one side than the other, so be aware that you may want to think about feeling lateral aspect to lateral aspect and medial to medial, and then the same around on the ankles. That you want to feel both sides with the same part of your hand and with the same hand. Again, after you've done that, try to push any fluid from that prepatella bursa into the knee itself. You want to be watching all the time, because if there is fluid here, you may be pushing it in and seeing a bulge right here on that medial aspect of the knee. Right? As that happens, it might fill with fluid and you might see an outpouching right here. So be watching. There may already be some swelling, and it may or may not increase at that point. The way that we examine for fluid now is by trying to push all the fluid out from one side of the knee, back into the knee, letting go and seeing if there's any fluid there. And then we go to the other side and push with our thumb to see if we've pushed fluid in the opposite direction. What we're trying to look for is called a fluid wave. So we push, get the fluid out, be patient, let go, and then push again. Try to be patient. Often I see people doing this, and there isn't enough time to really relocate that fluid. So be patient as you're doing that. And then you're going to go from one knee to the other and check. If you find nothing and your patient is coming complaining about knee pain, think about other causes for knee pain. So very common cause for knee pain is Osgood-Schlatter. That's an enthesitis, pain where tendons insert to bone. You might find this area here, the tibial tubercle, might be warm, occasionally even a little bit erythematous, and you might even see a little raised bump. So you can feel here underneath the patella, see if that's warm. And often if it is inflamed, it's quite tender. So give it a gentle push right here and check for tenderness. You could also get some enthesitis at the inferior pole of the patella itself, right here or here. And that's also enthesitis because as some of the fibers of the tendon from the quad muscle come down, they wrap around the tendon like the bread of a sandwich. The patella is that filling of our sandwich. The tendon goes down here, but some of those fibers actually stick onto the patella itself, securing it into that middle, so that it really is stuck, embedded into that tendon. And so it's fair game to have some inflammation at the bottom of the tendon, of the patella itself. So again, this could be a tender spot as well. So those are things also to check for. Another thing to check for knee pain, commonly in a patient who says that they have knee pain while walking, while running, while climbing stairs, when they crouch down and stand up. That's a very common complaint about patella femoral syndrome or chondromalacia patella. And we'll ask the patient to tighten their quad muscle very tight. There we go. You can see it tighten and then relax. And we'll put our hand right here, just above the patella, and ask them to do that again for us now that they know. Good. And if that bothers them, this is called a positive patella inhibition test. And that means that while the patella is stuck inside that tendon, if the lateral aspect of the quad muscles are pulling stronger than the medial aspect, it will pull the patella over to the side. When we're holding the patella here, not allowing it to shift, we're inhibiting the movement. If it's painful, it's considered a positive patella inhibition test. And that is consistent with the diagnosis of patellofemoral syndrome. Right? And we'll talk about that in a little bit and explain how we manage that. We're going to move down to the ankles now and show you how we do an ankle exam. The best way to do an ankle exam is to look down on our ankles. We want to look and see if we can see the nice contour along the ankles. So try to look from above. You can stand here where I am or stand at the end of the table and look down on the ankles. Take a look and see if they're symmetric. Do you see an outpouching along part of the malleolus that you don't see on the other side? Then you want to hold the foot at a 90-degree angle and try to feel along the joint line on both sides. So here I'm going to feel along this joint line here and see if I can feel any fluid. Now there are fat pads on the foot which can look like swelling. So you do want to be careful not to be fooled. They're right at the top of the foot here. And we're actually feeling just below that, just proximal to that. So be careful not to get tricked and think that that's actually some swelling. You can have swelling of what we call the midfoot, which is the dorsum of the foot. And that can be very tender and swollen. It's often quite warm as well. Never forget to look at toes for swelling. It's very painful to have a swollen and inflamed toe. So take a good look at those. Remember, you're not comparing this toe to this toe to this toe, but you're comparing the left first toe to the right first toe, and the second toe on the left to the right second toe, and so on. Okay. For movement of ankles, look at inversion, eversion, dorsiflexion, and plantar flexion, and look for symmetry. You want to make sure that one is moving in the same way that the other is. If one is moving all the way in and the other is not, that would be abnormal. Okay, so that concludes our joint exam. And now we're going to talk about what's the differential for some of our more common joint pains. Okay, so we're going to go back. And I think you can see now my slides again. And let's go back here and finish up. Our exam is done. Now what comes next? So do we need to talk about labs? And really not much. So the only things that we would think about in terms of labs is if we find a swollen joint. So if there is a swollen joint, then we would do some lab work and we would do a complete blood count, a chemistry panel, and I like to do the full chemistry panel because I would look at liver enzymes and albumin because this helps us in the event of a viral syndrome, potentially systemic juvenile arthritis, inflammatory bowel disease. So it's a good idea. You may as well, same amount of blood. And so I do like to do that just to give us hints at other things. And inflammatory markers, sedimentation rate, and C-reactive protein. If there is fever, that's when you consider doing a blood culture. Rarely in pediatrics is there ever a need to tap a joint for culture. The only time is in the event of septic arthritis. Otherwise, we really don't need to be tapping a joint. In the adult world, it's done frequently for a monoarticular arthritis, but again, very rare in pediatrics, because in pediatrics, we often find monoarticular arthritis, especially in JIA. And then depending on the case, we might consider Lyme, an ASO titer for strep, parvovirus, and mycoplasma titers. Other things for swollen joint, because it's pediatrics and we don't like to send children for blood tests frequently, we would do ANA, rheumatoid factor, and HLA-B27 for juvenile arthritis. Again, that's only going to be important if the joint diffusion lasts for 6 weeks. Those are labs that are important to help us understand the course and prognosis and so forth for juvenile idiopathic arthritis. They do not in any way help to make a diagnosis of JIA or rheumatic disease. So please don't think that even if positive, they help you to predict whether or not that child will have JIA or any other disease. There is a false positive rate on an ANA, depending on your lab, between 5 and 30% in the healthy population for an ANA. So it is not predictive, right? If you are concerned about a connective tissue disorder, you may want to send an ANA. So again, depends on the clinical story. But in a teenage girl who maybe has fever, maybe a rash, maybe some other blood test abnormalities already, you might want to consider an ANA for lupus or mixed connective tissue disease. Imaging, we rarely use. So it isn't used very frequently to help us in working up joint pain. So only in very specific circumstances. Very rare for trauma. In young children, trauma is not very impressive that they would fracture something. So in toddlers or young children, it would be very uncommon, even with a swollen joint, for them to have had so much of an accident that it caused that kind of swelling. So that makes us think more about JIA. If you're concerned about maybe osteomyelitis, malignancy, maybe, so think about that for infection. For arthritis, doesn't help us to have an X-ray. Only in really long-standing arthritis might we want to see if there's been some bony changes or some damage because of long-standing undiagnosed arthritis. But there can be joint effusions that are not seen on X-ray. If you're unsure about whether or not there is a joint effusion, consider ultrasound. No radiation, easy, inexpensive, and you can get ultrasound, especially in a small child or a thin child. You could even do the hip. And then MRI could be useful. It can see many things that aren't picked up by other modalities. And then bone scan could be helpful as well, looking for infection and other things. We often don't do bone scan anymore because it's been replaced by other things. Now, I'm just going to mention some of these common syndromes, and this is absolutely by far the #1 thing that we diagnose for joint pains in school-age children. And statistics are a little tough to pin down on this because so many kids just aren't diagnosed. And most children are called growing pains, but benign hypermobility syndrome of childhood, absolutely the most common cause of joint pain in school-age children, and even all through school age. We used to just say elementary school, but it really goes all the way through high school. And the very fancy name that I mentioned, benign hypermobility syndrome, orthopedists call it ligamentous laxity, and the common name is double jointed. And I'm going to show you a diagram of what this means. But I mentioned a bit earlier that the typical story are joint pains that happen more in the afternoon or evening. They come with activity. So on a rainy day, these kids don't complain much, but when they're really active and doing things, they will have more pain. They're short duration. They'll complain a lot. They may cry. It could even wake them from sleep, but then it goes away. The parents frequently tell us they are going to bed and that's when they're complaining, or they wake from sleep and the parents massage their legs, and it could be the right or the left. It tends to be non-specific. So it could be the knee, the ankle, the thigh, and it goes from place to place. It's never the child that complains only of the left knee. That will not be hypermobility syndrome. So it should go back and forth, and it should be bilateral. And it tends to be lower extremities far, far, far more than upper extremities, if upper extremity at all. What we tell parents to do for this is very little, because it's so harmless that the best thing for children to learn is to give a little stretch and move on. And it's much more adaptive for them, even if it wakes them from sleep, to stretch out that whatever part it is that hurts and then roll over and go back to bed. If they're walking a lot, it's more of a tendency when they're bored or something they don't like doing that they'll stop and say it hurts a lot. And we tell parents to say, okay, let's give it a stretch and then count and then move on. And they should be just fine after that. So minimal attention, because again, it's not something that's harmful, and that helps to reassure children as well. And then very supportive shoes. A firm heel counter. So the back part of the shoe, the heel, you should not be able to pinch the sides together or push the heel down. And then some arch support, which now they can buy over the counter. We do not recommend custom orthotics, which are quite expensive and really not necessary. If they're very hypermobile, think about Ehlers-Danlos or Marfan. This is the very, very mild form of Marfan syndrome, but it does not have any other sequela. So here's what we look for on exam. And these are the features. So if they have their hand like this, we have them bend their thumb back and it can actually fold. I am not double jointed and cannot show you, but the picture displays this nicely. And so their thumb goes all the way back. The fingers go back to form a nice U shape here. Their elbow in the middle picture here bends backwards. Their knees bend backwards. So you can do this lying on the exam table as well. So if you hold your hand, one hand on top of the thigh and put one hand underneath their calf and then pull upward, their ankle will come up off the table and show you that their knee is hyper flexible. Right? And so these kids are very, very flexible. So we recommend in the summertime not to wear flip-flops if they're going to be walking a lot, or sandals. They need a shoe with a backing. And you can be the hero and fix their joint pains very, very simply. Right? Now, this is the trash can diagnosis, growing pains. And what most people call those very mild aches and pains is actually growing pains. However, most kids are hypermobile. There's no harm in calling it growing pains. It's just that when you do identify hypermobility, there's something to do for it by helping with that supportive shoe. Growing pains is a true entity. It happens in about 35% of children. I honestly think it's a little overdiagnosed because of the hypermobility, but this happens between the ages of about 4 to 6 to teenagers. It's a misnomer. It doesn't necessarily have anything to do with growth. It's usually lower extremities and it's usually muscle cramping. It happens at nighttime. They're better by morning. It also can be improved with some massage or stretching. No joint swelling either, really no other symptoms. So these two entities really are responsible for a lot of those harmless pains, and neither have sequela, fortunately. Now, I showed you this on the musculoskeletal exam, Patella femoral syndrome. Very, very common in teenagers. And some teenagers will actually tell you they hear this grinding or popping, or their knee might lock, or they're walking and suddenly they feel like their knee gives way. And that's this patella femoral syndrome. And it's a muscle imbalance where the lateral quads become stronger than the medial, which is really common in our day-to-day activity. And so what we need to do is have them strengthen the medial quads. And you can have them stand up and take a ball, not a basketball or soccer ball that are very firm, but the kind of ball you would teach a little child to play catch with that's really soft and you can squish a little bit. Have them put that ball just above their knees and squeeze their thighs together. Count slowly to 5 and then relax, but don't let the ball drop. And then squeeze again. Have them start by doing 10 repetitions every day. And then after 3-4 days, when that's easy, go up to 15 repetitions and then again go up to 20. Once they can do that easily, they can squeeze that ball, and rather than counting to 5, they should count to 10. That will strengthen the medial quad muscles, and that will stop that tug of war that's going on. So that equalizes the muscles and the patella won't be pulled off track any longer. And it's a very simple fix. Right? And that should stop that pain. Truthfully, the inevitable happens and the kids stop doing the exercises and the pain comes back and they need to be reminded to do this again. but it's a very simple fix. I showed you that Patella inhibition test. It's often positive, but not always. And if it isn't, it's okay. You can go based on history. Fever and arthritis, it could be infectious or post-infectious. I mentioned malignancies could present this way. Systemic onset JIA. We talked about connective tissue disease like lupus, or inflammatory bowel disease could have fever with arthritis. So this is the differential to keep in mind. So the infectious and post-infectious, septic arthritis and osteo I would leave to my ID colleagues. They rarely come to our office. They're usually in the emergency room or the ID office. But reactive arthritis and toxic or transient synovitis, we see a fair amount. Parvovirus, Lyme, and rheumatic fever. So reactive arthritis, lots of viruses, can't possibly test for them all, and it doesn't truthfully matter. These tend to resolve completely by 6 to 8 weeks. Most of them are so much better within a week or two, but we do treat to help the children feel better with some ibuprofen. They may have some fever still by the time we see them, and they may have a slightly elevated sedimentation rate or even white blood cell count. It's often a single joint, but it could be multiple. Toxic or transient synovitis is just the special name given to reactive arthritis of the hip. Other than that, it is very similar to reactive arthritis, tends to be in the 3 to 10-year age group. Parvovirus, if you're sending labs, please remember to check the IgM because it would need to be an acute infection. And the thing that's special about parvovirus, as opposed to other reactive arthritis that affects large joints, this can affect small joints often. And here is Lyme. It's an acute, and the acute infection would be this rash here, right? That target lesion, and that's erythema migrans. And here is Lyme arthritis, this very large knee, which is the most common, right? This comes months after the acute infection, and they may never remember having had that rash. So we do want to do the Western blot test for that and treat them appropriately with antibiotics. Rheumatic fever is something to keep in mind. So I just put here Jones criteria, and they need to have evidence of a preceding strep infection, and then we count up our criteria. If they don't meet criteria, there is a special reactive arthritis called post-strep arthritis, where they don't meet criteria, but we do have evidence of a strep infection before with an arthritis. Typically large joint. These children, we do prophylax still for a year with antibiotics. And this is just the rash, just to show you what it looks like because we don't see it often anymore. Malignancy, just one reminder, it's typically pain out of proportion to clinical exam. So joint or bone pain, but it could be true arthritis also. And it can look a lot like systemic JIA, which is why rheumatologists see it. The other thing to keep in mind is disproportionate labs. So if we see still a normal CBC, but a lowish white blood cell count with a high inflammatory marker, that should not happen. White blood cell count and platelet counts should elevate proportionately with a sedimentation rate or CRP. So please keep that in mind. And I just want to show you the sites of enthesitis. I know I pointed it out on exam, but these are lots of sites where tendons insert to bone and can be painful. These are the most typical: the tibial tuberosity, Osgood-Schlatter, inferior pole of the patella, Syndig-Larsen-Johansson, and the calcaneus, which we call Sever's syndrome. And here is Osgood-Schlatter. You can see this big bump here. So very common, these musculoskeletal pains in childhood. Usually does not stop activity for children. They will keep going. Look for those typical causes. History and exam should tell you most of what you need to know, and we rarely do testing on these most common causes of musculoskeletal pains. So I hope this was helpful for you, and I'm more than happy to answer any questions.
Thank you so much for this wonderful lecture, Dr. Gottlieb. Excellent overview of physical maneuvers, physical exam maneuvers, which I think it's very important, as you pointed out. We do have one question by Dr. Bahadouri. She's asking, with adequate treatment, what is the prognosis of juvenile idiopathic arthritis?
So that's a great question. So JIA, for us, we have multiple subtypes of JIA, and truthfully, the prognosis really differs based on the subtype. So the vast majority of children will have oligoarticular, meaning arthritis in 4 joints or fewer. They do have the best prognosis. And then we have polyarticular arthritis, 5 or more. We have those that have a positive rheumatoid factor, enthesitis-related arthritis, systemic arthritis. So it's actually a complex question because prognosis varies depending on the subtype. So I'm part of a group that's a quality improvement learning network that's North American wide. And we have some data that has not yet been published that we unfortunately are learning that the prognosis is not quite as favorable as we once thought. And we're looking now at patients who are relapsing after coming off their medication in the percentages of about even 50 to 70%. So the ones with oligoarticular may be around the 50% mark, but those who are more involved, polyarticular juvenile arthritis, are up to 70 and 80% relapsing off medicine and need to go back on medicine.
That's a high number, right?
It's a very high number. They do extremely well on medicine. And the medicines are fantastic now, fortunately, and children monitored on medicine can do extremely well very safely, but unfortunately, it's a very high relapse rate and not as encouraging as we had thought.
Thank you so much for your answer. And then I have another question, just out of curiosity. What I understood was that juvenile idiopathic arthritis has nothing to do with the rheumatoid arthritis. The patients with JIA have an increased risk of developing rheumatoid arthritis later on, or is it just a different disease?
So that is a great question. And we don't really know what to call those patients when they grow up. You know, do they continue to have arthritis? It's all becomes very blurry. And I'll tell you, I know that when they walk into the adult office, they just stop calling them JIA and now they're RA, and we don't even know if that's fair. Genetically, they are mostly distinct, and the ones that genetically are similar to adults are the rheumatoid factor positive polyarticulars. The others we feel have a distinct genetic type, and we've actually shown that in some of the genetic studies. So the other children, some of them who have outgrown, so to speak, their arthritis, the oligoarticulars, may not be at more risk to have inflammatory arthritis. Some of them may have some joint damage and could be at higher risk for osteoarthritis, the wear and tear arthritis that we're all at risk for, unfortunately, as we age. So that could happen to them in a higher percentage. But some of these kids are going on and flaring again, or may still continue to have some arthritis into adulthood. It's a very difficult question, and we're only starting now to follow those children into adulthood. We had not been successful in tracking them into their adulthood before this. So we're just learning that.
Very interesting field, and thank you so much for all the work that you're doing in this to solve these ongoing questions. So we do not have any other questions so far. So thank you so much for your time and for this wonderful lecture again.
Good. Well, thank you so much for inviting me. It's been a pleasure.